sciences, computing and analytics, media and communication, design, engineering, and technology. Today, we are also having the students of Department of Hospital Management from the Tamil campus with us. Through Facebook live stream, we welcome them all. It's my pleasure to introduce to you all the eminent speakers whom we have invited here today to share their knowledge and experience with us. Dr. Joy with us, so please have your seat. And Mrs. Super Banerjee, please have your seat. We were supposed to have Dr. Shubhrajyoti Homi, Clinical Director of Peerless Hospital among us as a speaker, but due to some personal exigency, he is not present today. We would like to listen to him in future.
Now I would request Abhay to present the sapling to our speaker, Dr. Joyanta Das, as a token of our delight and respect. Now I would request Shaun to present the sapling to our speaker, Mrs. Durga Banerjee, as a token of our love and respect. Now I would like to request our professor, Dr. Chilam Rudradev, to come here on the stage and introduce the speakers and start the session.
Good evening all. Am I audible? Good to see such a number of students after many days in the session. So as you see, today's topic is impact of technological advancement on patient safety and quality of healthcare. As we all know that as we have all seen when we have gone to the hospital as a patient, the interns, or when we have joined the jobs, like technology has advanced by leaps and bounds and brought about different changes in every industry, and healthcare industry is not an exception also. So what we know about or what we felt about the technological advancements as the common people, so nowadays we have different medical apps to have the quick medical information so that diagnosis can be done truly in sense very quickly. We have different sorts of electronic medical record system. We have different improved communication system, telemedicine. So we have several things. We have robotic surgeries, whatnot. But the thing is that we are also in need of patient safety. It is such a situation or such a what to say, such a thing to be considered of concern worldwide. So how these technological advancements, which we are actually seeing, watching, observing every day, how it is having some sort of impact on this patient safety, that we are going to discuss today, and will be enlightened by our two guests who are from the public sector as well as Dr. Joyanta is from the private sector, and we think that we'll get the focus, the highlight, that how they actually manage this technological advancement and patient safety hand in hand. So let me introduce the speakers today. So first, I am taking the privilege of introducing Mrs. Durga Banerjee. Being one of the toppers in her Masters in Healthcare and Hospital Administration from Indian Institute of Social Welfare and Business Management, Kolkata, which is a premier management school of the state. She has many other feathers in her hats. She started her journey as a manager in Bhagirathi Neotia Women and Child Care Center. She has 17 years of experience in the Department of Health and Family Welfare, Government of West Bengal. Other than that, she was a program coordinator in the Department of Biochemistry in All India Institute of Health and Hygiene. She has acted as nodal officer of different critical units of different government hospitals, and currently she is working as the Deputy Superintendent of Srirampur Wash Hospital, Hooghly. And besides all this, she is also a certified quality assessor. So a big hand for Mrs. Durga Banerjee. Okay. A long breath before introducing Dr. Jayanta Dash, a man of many significant aspects. So many areas to cover at a time that I need to have a long break before that. Dr. Dash did his MBBS, FMS, and also his LLB, as he has interest in diversified areas. He is not only a renowned vascular and endovascular surgeon of Eastern India, but also a medical record expert with different sorts of experiences in this field. He is also the Vice President of Indian Association of Medical Legal Experts. He is an executive committee member of Venus Association of India and active member of various other national and international committees and associations. As he is interested in academics too, he always loves to interact with students, be their faculties, mentors, and in many other forms. He likes to share his knowledge and expertise with the students. He is also associated with different institutions and universities in India and abroad. Other than that, he also acts as a member of review committee of various international journals of medical research. So don't you think that he is a man of different diversified areas and significant aspects? So a big hand for Dr. Jayanta Dash too. Okay, so in today's session, Dr. Dash, how we want to proceed? So shall I ask you some questions, and based on that, can we take on the floor? After the session is over, the discussion is over, definitely I think the students, you will also have some questions. So please listen to the session, listen to the speakers, and be prepared whatever questions you have in your mind to get back to us. Dr. Dash, we generally always use the term patient safety. So patient safety, as a common man, we know that whether the patients are safe in the hospitals. But what as a clinician or an expert in the hospital, what do you feel patient safety is, and how do people measure or implement patient safety?
Thank you, madam. It's a very pertinent question and it's a very important aspect to start any discussion related to healthcare and patient safety. Before going to the particular question what you have asked, I like to emphasize on few basic fundamentals. It's an academic institution. Most of them are students, and I can see the faculty are sitting in the front row. We tend to think many fancy things but without get hold the exact crux of the story. We all talk about safety. Patient safety is a subset of whole safety issue or safety concept. Today we are sitting in a building. There is electricity. The building is made of concrete and whatever technology at this moment available. Are we safe? Yes or no? Yes. Why?
This is what we have, and for this season we are seeing as in the pure ones.
Because that you feel. Because you do not know how the technology is being made, how this building should be. So safety concerns two fundamental human psychologies. One, you have to know the risk, and another is how that risk has to be mitigated. So fundamentally, if I ask you what the safety is, now it is a very difficult question to answer. Can anybody answer what the safety is? Forget about patient safety, building safety, fire safety. There are a lot of safeties. What is safety? Anybody can answer. When I was in a management school, though I never grown as a management guy, I have interaction with management school, including the IIM. So there is a very fundamental question I learned in some conference. The first line saying the safety doesn't exist. By definition, safety in a state is perceivable as absence of risk factors. That is safety. So if there is no risk, only then you are safe. Now risk can be visualized, you can perceive, or you may not perceive. একটা বাচ্চা যখন খুব ছোটবেলায় হামাগুড়ি শেখে সে কিন্তু প্রদীপের আলো দেখে তার থেকে লাফিয়ে পড়ে আমি গিয়ে পড়বো না প্রভাবে নগরে হই কারণ আমরা জানি ওটা করলে আঙুলটা ঘুরতে পারে একটা বাচ্চা জানে না সুতরাং না জানলে যে কোনটা রিস্ক তার পক্ষে সেফটি মেনটেন করা সম্ভব না সো ফার্স্ট অ্যান্ড ফরমোস্ট থিং আমাদের এটা বুঝে নিতে হবে we have to realize safety doesn't exist. It is the risk factors or risk which does exist. And the mechanism of whatever we do to mitigate that risk or minimize that risk, that is called safety. So safety is a state, it is arbitrary state which doesn't exist in reality. It is a state in which risk factor is zero. That is the ultimate definition of safety. Now we are coming back to our today's discussion, patient safety. If you consider a patient inside a hospital, it can be in the clinic, it can be in anywhere, it can be in a laboratory, in our CT scan machine, MRI machine, or under operation theatre, under ICU, anesthetized, and intubated. In healthcare segment, we have curtailed down a little bit of safety concern. Probably it is principle-wise same. We know if you come to me, I am a surgeon, I have to operate, so I have to give certain amount of incision. Otherwise, it's not possible. So there is a risk factor to you. But in a conceptual framework in healthcare industry, safety means reduction of unnecessary harm. It's not no harm. It is reduction or managing things so that we can reduce the unnecessary harm towards zero. One small example, most of you may have experience of putting an IV drip for saline. I have to prick once to put in one saline. If I can do it by single prick, then it is the minimum harm I am doing to you for a greater good. But if I prick you 5 times or 6 times to get an IV access, this can be reduced up to 1, but it cannot be reduced up to 0. So I am curtailing by training and various mechanisms. These 5 pricks should be come down to 0, and in a hospital setup it should be only 1 prick to each and every patient. So our doctors and nurses to be trained in that. So our safety concern is curtailing down unnecessary harm, not making the harm zero. Now, in a healthcare institution, if you think about the patient safety, patient will be interacted with either some sort of human being or some sort of machine. How exactly routine life works. Come back to your room. If you want to switch on the fan, you have to put somewhere switch so that fan can be on. This terminology is not written in any medical book or medical book. It comes from the industry, that's the technology. There has to be a human interface where human interacts with other human or other instrument and equipment. So if we consider the patient and a nutshell, patient is touched by either some person, it can be doctor, nurse, technician, anybody in the healthcare industry, or by some of the machine. If this person or patient is touched by some of the machine, say I have ECG leads. So actually leads are touching me, not somebody else. So this is the interface of a human being or patient with a ECG machine. This interface at end of the road it will be some sort of human being. So ultimately patient interface in hospital only two. One is patient to other person or patient to some sort of instrument or equipment. If it is instrument equipment, then that has to be controlled by some person. So this cycle goes on. So if we can optimize this interface, then the patients will be safe as per healthcare standard. That risk is not zero. Unnecessary risks are minimized as possible. In an example of putting in a brick, one single brick is possible. So if you consider as a healthcare manager or administrator in the healthcare industry, you are in a quality department, you have to increase the quality. So your efforts regarding this brick has to be done in a single shot in a perfect manner so that the patient doesn't require to break twice or thrice or minimum time. So all the technological advancements are actually in towards that way. Another thing is very important. Probably, I don't know whether you have heard this terminology called Gemba. Have you ever heard this? It's a management term. Gemba is a Japanese word. It means place of operators. Until unless you have experienced to place of operators, how it is being done, what exactly it is very difficult to perceive sitting on the chair. If you want to proceed, come to the real world and see, and then you think how things can be made more little better one. So we have to optimize the interface. This optimization has two parts. One is the human resource development, that is the whole industry and academic system which is basically developing human resource. I was trained in medical college, then trained in surgery, then if any new instrument is coming, now say when I was trained, then laparoscopy was just introduced. So we needed specific training for laparoscopy. Now robotics is coming up. So if somebody is interested, robotics he has to be trained or retrained in a robotic surgery. Otherwise it's not possible. So it's a graded manner. This is one set how we can minimize the risk factors. Next phase is instrument and equipment. Yes, there are various generations of instrument and equipment and they are quality-wise improvised and how better things can be done. Real life example, I don't know how many of you have seen the black and white color TV. I have seen at class 10. My 4-year-old boy now shows me some video in YouTube, in smartphone. I saw black and white color TV at class 10. Now probably whoever is present in this room, nobody has seen color TV, black and white TV at their home. Now it is LED, then it is plasma, now on top of that 4K, now even 10K television is available. So technology is improvising. How better can be served? The same principle applies to healthcare industry as well as the instrumentation equipment. This is one pipeline by which we can make things safer for the patient. Last but not the least, it is the patient education who is actually taker of the service. If you such a gesture and the patient says, no, I am not interested to take this from you. You don't touch me, I don't want this late. So you need patient availability, he has to comply. Teachers can groom you, but you have to at least learn. Teacher can bring you at the river, but they can't make you force to drink. So patient education is another aspect. And in true science, we don't have time to educate the patients. Doctors are very busy. If they are busy of 50% and 50% business is show off. If you come to the hospital, everybody will have similar kind of experience. It may be 50 or 60%. I am busy 50% and I will show I am busy 100%. This is how the attitude aspect of an individual works in a interface level. So, in a healthcare institution, if we have to improve our scenario and patient safety, so whatever the interface we can assume, we can think, we have to think to improvise that each and every that interface level. This is the fundamental story, and that's the basic thing I want to convey to all of you.
Thank you, Dr. Dash. Mrs. Banerjee, now the question goes to you. As sir has said about there is no such time for patient education, and since you are in the government setup, the number of patients, I mean not that much, every patient is much more, and the number is also huge. So how do you people think that you take care of those patients having some specific patient safety goals?
Thank you, Dr. Tina Kudrave, for this question. And with due respect to one of my speakers who is sitting right beside me, to the principal, to all the professors and the coordinators, and to the beautiful and lovely students who are sitting right in front of me, this is showing actually good vibes that I am taking, that you all are listening. The these are patient safety goals. Can you all tell me what is actually patient safety? Any idea from you? As because all of you are undergoing hospital management course here, can you please tell me, anybody, it's just a normal discussion. Sorry, come again. Okay, now I will just enlighten a bit onto this. First and foremost, patient safety is the first thing that strikes in your mind is to do no harm. First to do is no harm to any patient, those who are coming to the hospital. So, based on this theory that no harm to any patients, we have certain patient safety goals. There are certain patient safety goals which adheres to every healthcare establishment, be it private or be it government. What is it? The first and foremost is you have to identify the patient properly. Being a clinician or a nursing staff or any healthcare provider, the patient needs to be identified properly. How do we identify the patient? The patient must have a band onto his or her arm. Have you ever noticed and have you ever visited any hospital? You will see that all the patients are having a number on the wrist, a number band on the wrist, which reflects that this is the identification number of the patient. And this patient is under which doctor, that will automatically be derived, and from the clinician part also, the doctor will immediately come to know, okay, this 365 number patient is my patient suffering from maybe gallbladder, maybe appendicitis, or maybe any heart problems were admitted in this hospital. Even this band, with this band, the nursing staffs will also, be secure to provide treatment or to provide medications to that particular patient. Second safety goal is communication. Communication between the health providers and the user. impart that knowledge to the patient and to inform the patient about each and every decision making of his or her diagnosis or prognosis, as you may say. The third aspect is keeping the high alert medications safely, administering the high alert drugs that is being prescribed by the clinicians. Those should be kept very securely, separately, and it should be labeled. The expiry date should be mentioned so that no medication error arises. So this is the third goal that all health providers or the healthcare establishments they try to achieve. Fourth is what? I have a surgeon sitting beside me, Dr. Das will definitely agree, that is safe and secure surgery. Safe and secure surgery. This is established through different surgical checklists. I think the private organizations also have, and the government institutions also have safe surgical checklist. This all comes under aspects of quality. These are all quality aspects that has been, embedded by the Ministry of Health and Family Welfare, and that has been organized by the state. So this is the fourth aspect. Fifth aspect is what? That is hand hygiene. Infection control practice. This is the most vital part. The thing is that infection control practice. There are 6 steps of hand washing that everybody must adhere to. The 6 steps of hand washing are very important in any healthcare establishment. And last but not the least, the thing is that prevent any patient to get any harm from any fall. We have to prevent any patient to get any sort of harm from any fall, to avoid any sort of adverse reactions or events in the hospital. For this, if we can prevent always from the hospital part, from the management part, or from the clinician part, we will help to, get into any sort of litigations that might arise. Often you have, you people see in the, TV or in the newspaper that the clinicians got, harassed, or maybe the nursing staff got harassed, or maybe the administrators got harassed. So, if you prevent all this, those things can be, mitigated. Thank you so much.
Thank you for the concepts that we have come to know from both of you. Since Durga has mentioned about the quality, so as per in the private sector as well as in the government sector, what do you think that what are the different challenges you have faced? Any experience you want to share? Challenges you have faced regarding this patient safety?
Again, it's very easy to say things, very difficult to be implemented. Actually, those who make policy, they have no relation with the crowd. Sitting in the room making certain policies actually doesn't work. And first challenge in our setup, I am not distinguishing the government and private setup. It is the same. Quality goals and what should be done, it is same. Next comes the liability. If you cannot put somebody behind the bar, you can't make him liable. Simple fun, try to understand. কাউকে যদি কোনো একটা কাজের জন্য জেলে না পড়া যায় তাহলে তার কোনো এটার কোনো সলিউশন নেই, এটা কোনো সলিউশন নেই। এবার the problem is everything if you want to do you need a cost. If you come to national statistics, it was 2.5% of our GDP 3 years back. Now government announced policy it should be dragged down to 1.5%. This is the official figure. Exact, you can understand. To have a quality healthcare, what are we actually dreaming about? We need on an average 10 to 12% of a national GDP to be spent on healthcare. It is something like that. We are expecting American healthcare with Ethiopia. Say for example, if you are a aviation engineer or you make aeroplane, you came to me and your ambition is to make me understand how jet engine works. It is practically not possible. First is my limitation to understand that technology. Because to understand that technology, I need to understand many basic technologies. It is same, somebody who is not from medical industry, to make him understand CT scan করতে গেলে কি কি হতে পারে আপনি অপারেশন করতে গেলে আপনার কি কি হতে পারে and if this interface is never surrounded then you are flying in a jet airway say no jet is not there in you and if you are start talking with pilot আচ্ছা আপনার এই সিস্টেম মানে কি আপনার এটা যদি দরকার আপনার কি হবে do you think pilot will be able to fly that plane? Now, our problem is that in healthcare industry, everybody has right to ask questions without their capability of digest. That is the biggest challenge, and it is more bigger challenge in government. Don't take me wrong, most of the affluent class comes to private sector, and in government setup, that much affluency we don't see usual. Exceptions are there, but it's not usual. So on an average, if you are from NSHM, in this PMP, you will assume you are a little bit better than somebody in the pooling and same level of education or qualification. So in a private setup, the overall general education and awareness is better actually easier to make you understand. Comparatively. And there are also little bit of English. It's another problem. But at the same time, if you go with somebody in a rural hospital and you want to make you understand how appendectomy has to be done and what is the difference between open appendectomy and laparoscopic appendectomy, other operations are not. So this is the biggest challenge. Our overall societal economic situation, government funding in healthcare, and at the same time general awareness and education. আমাদের যদি এখন মানুষের ঘরে নামটা বলতে বলা আমি বাংলা নিয়ে পড়েছি নামটাই জানতাম ওয়ান টুজার জিন্দা আমি তারপরে বড় হই কাউকে যদি একের নামটা দুয়ের নামটা তিনের নামটা না শিখিয়ে মানুষের নামটা বলতে বলা হয় তার যা হাল হবে আজকে আমি যখন কাউকে একটা ব্যাচেলর সার্টিফিকেট বুঝাতে চাই হালটা টাইম হয় কিন্তু পেশেন্ট রাইটস এবার অনলাইন অ্যাভারেজ আমি যে সময় পড়াশোনা করছি ধরে নিচ্ছি সেই সময় আমি অ্যাভারেজ স্টুডেন্টের থেকে বেটার ছিলাম তো আমি ছাড়াও ছিলাম কিন্তু আপনি ঠিক রাস্তা বের করলো করে কত কম কথা বলে পাস কাটিয়ে দেবেন most of the high-tech doctors you will find this phenomena in a different name or different category. You go to too big hospitals, there will be one or two layers of secretarial management who doesn't know anything apart from people. So you won't be able to reach. Fine. I will use few others, knowing that you will be able to understand at some point of time you will keep consent. That is how really what it works. But what is textbook teaching, what Madam was just saying, I have to make everybody understand that. In true sense, it is not possible. Don't have any fancy idea. It is very good on the stage and textbooks. not in real world. That's it.
But Dr. Dash, isn't it the right of the patient to know that what is going to happen to him or her?
Yes, ma'am, it is right. Absolutely right. Indian government has a charter of patient rights. 17 rights written there. It's available. If you Google it, even if you can find it, Ministry of Health and Family Welfare, central government, they have recognized 17 legal rights. All these rights derived from our constitution, Indian governmental various kind of convention with the international agencies, including WHO, and other countries. You will find everything is patient rights. Why? Because these rights are derived from the political interference of scientific event. These rights are not derived or derived from the scientific event to political. So it is always healthcare is always a political ballgame, whether you love it or you don't love it. So giving the political ballgame, so the policies and regulations will be in that way what the ruling government is in a favorable situation. So in whole India, if you consider the number of allopathic doctors, it's not even 1 lakh. Coming together, homeopathy, allopathy, and dentistry, it comes around 2.5 lakhs. We have 140 crore population. So, and if it is 1 lakh, 10 to 15% is basically their name is there. They are either 70 plus, 80 plus, they don't work. So effectively, we have roughly 80 to 85,000 doctors throughout India. It's not possible. To have this, we need to build a huge number of colleges. We need to build the infrastructure. Forget about medicine, I am coming to your institution. If today I want to establish a medical institution, the number of faculties I require, it is very difficult to find in the program. Very difficult. So there is a huge discrepancy in fancy ideas and reality. At the end of the day, we have to be realistic. If we are not realistic, we have to suffer. So that is how this will work.
Okay, we got the viewpoint from a clinician, who is one of the renowned surgeon of this part of the country. So, can we have some glimpses from an administrative?
Yes, thank you, Dr. Chena. From the administrative level, I absolutely, is a clinician. What is and is absolutely right. The health facility network to endeavor all such things, human resource is required, budget is required, finance is required, all these movements are required. But keeping aside all this, I would like to just highlight some things of patient safety that we have faced in our institute. One day, when we were giving lungs, okay, one of the patients on the bed wasn't there. One young chap, aged around 28 years. The nursing starts tapping in the door. কোথায় গেল পেশেন্ট দিদি পেশেন্টকে খুঁজে পাওয়া যাচ্ছে না সে কোথায় চলে গেল পেশেন্ট ঠিক আছে এইবারে খোঁজো 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 everybody everywhere they were trying to find out where the patient is. Security was standing on the gate. Security was questioned. Now suddenly we just thought we should check the bathroom. The moment we entered the male toilet, we found that the patient simply sitting on the commode, he lit the fire on the system. Maybe he was having some, second or something like that. But the patient had no such diagnosis with the bleach. So, this is a sort of adverse event that happened. And everybody in the security also health hazard to the patient, that could have caused a health hazard to the nursing staff. Though the fire alarm, the sprinklers just automatically go out. Sprinklers take it all for this the fire alarm system is made in that way. But the patient will have so the thing is that patient safety is done for the whole. I'm not getting it into any controversial arguments, but as far as our knowledge goes, from our viewpoint, there are the certain rights of the patients, certain responsibilities also of the patients. What যেমন patient right আছে, তেমন patient কেও কিছু নিজস্ব কর্তব্য আছে। হেলথ কেয়ারে এসে সেটা মানা। To keep the environment clean, to abide by the law that is being set by the hospital administrator, to follow the quality concepts. আমরা সবাই বলি in the healthcare institution there are 10 hours, but actually the government set up we follow 7 hours. 7 hours means that is implied, that is right medication, right dose, right food, right time, the right prevention, right documentation, all this comes under the patient rights. The medication point of view. So as far as patient safety is concerned, we should look into the physical safety part. We should look into the electrical safety part. We should look into the fire safety part. The technological advancements are coming into the government setup also. Then to the both from the staff and from the health providers and from the user end, safely the medications could be given and the patients could be treated without any harm, being caused to any clinician, being caused to any nursing staff, being caused to the patients. We have always noticed that immunization, after any immunization, specifically for the children and also for the adults, we have seen during the corona time that some are getting fevers, some are having diarrhea. So that also comes under the adverse event called immunization, that is the vaccine safety. There are so many safety protocols, just imagine. So all these things we must attend to. We need health service providers, electrical safety, all these lights. We should be having LED lights. Power audit should be there. That should be done by the maintenance staffs. And that should be recorded. That should be checked by the administration. All the critical equipments that are there in the critical areas like CCU, ICU, HDU, OT, labor room, SNC, NICU, PICU, all those equipments must be calibrated so that it doesn't give any medication errors. The equipment operations should be mentioned on the equipment. Like if any red alert comes, like in the disaster in the CCU, any red alert comes, say, okay, what this patient is having, like intubation should be given or the patient should be taken to ventilation. As we all see, certain codes are given for red or blue, all this sort of things are given. And if the process is mentioned on the equipment, then it would be easier for the doctors. A doctor is catering to many patients, both general patients, ICU patients, many patients, especially in the government sector. Specifically in the government sector. Just flash of a second, a nursing staff or a doctor, they might want to see, okay, now we should do this. Now, this week we should give the medication. This might happen in the government. I myself have seen this. I have seen Dr. Shoma Kamali asking you before I see, okay, then she was saying, oh my God, what I have to do now, I can check in the manual. It was just right there on the machine. And the chipper was 500 because it happens. We have seen So the thing is that technology has had to improvise. All these things have come into place. The physical safety, as Dr. Das asked some of the students in building the physical safety of the building, that is the maintenance and upkeep, is very important. That should also be checked. The seismic certificate should be derived whether the building is earthquake proof. That is only given by the Public Works Department of the government sector. And that is Medical Service Corporation also gives the physical certificates. Electrical safety, this I was talking about, this should be conducted. Physical access audit should be done for the mobility challenged patients. Those who are physically challenged, we see mobility challenged patients. Like the hand railings are there or not, the handicap toilets are there or not. Whether the steel is, there are no skatings on the steels. Whether the gradient is okay to move the wheelchairs or the trolleys for the patients. So all these things should be checked. Environment of the hospital, decontamination of the patient areas where the patients are staying, the surface, the beds, the biomedical waste areas, the infection control practices, all should be taken care of. All this comes under safety. This is very much required in every setup. This is very much required. Hand washing practices should be. So all these monitoring technologies are coming. Like in earlier days, MRI CT scan wasn't there. But now in every healthcare institute, we have MRI and CT scan facility. Why? So that the doctor immediately checks the reports and finds out, okay, what is the problem, and likewise in providing the treatment, it becomes easier for the doctors. A system has been evolved that we are trying to implement in our hospital, and it's PACS. In the radiology department. This is what? The system is what? The system is we are implementing this software that if the patient CRPR, then the X-ray is performed, automatically in the walls, when the mechanical engine is there and the computers are there, the nursing staff and the doctors would immediately see the X-ray of the patient. In this patient, the doctor doesn't have to come down again to the X-ray department. And neither the X-ray person has to then X-ray for that in the box. This is preventing, the wastage of time, the wastage of energy. This technology advancements are so very important. So, as far as my viewpoint goes, everyone must adhere to all this, starting from A category to Z category. Thank you so much.
Okay, since you have just mentioned about this technological advancement, we are talking about the special care and quality for the last few minutes. So can we have some concept of the role of technology in medical management nowadays? What are the things that are coming up and how we are gradually improving in this aspect?
Yes, madam. There are a lot of technologies that are coming out, and many are already improving in the healthcare industry, and many are in pipeline just because of cost factor and other resource factor we cannot implement. Say, for example, 15 years back, we have to write a and carbon copy, 2 or 3, one to the hospital, one to me, and original copy was given to the particular patient. It's a very small thing. Now we don't need to do anything. We don't need to do carbon copy. We just type in a system. The one copy will go to the patient's WhatsApp email, and if he is registered with the hospital app, his individual profile will get a all the investigation reports will go. Similarly, I can see opening my dashboard, the mindset. Now, technological advancement, whatever we see, what for technology? Technology is used to ease our life. Whatever it is. গরমে ফ্যান চালাচ্ছি আমাকে যাতে পাখা দিয়ে হাত পরিশ্রম করতে না হয়। So fundamentally, all technology, anything and everything, whichever you name and think about it, it is made just to ease our existence. This is fundamental. Now come to the commercial follow. সরকারি হাসপাতালে এখনো বোধহয় আছে যে ফাইল এই বিল্ডিং থেকে ওই বিল্ডিং নিয়ে যাওয়ার জন্য একটা ক্যাটাগরি আছে। If you come to a corporate hospital, you will see none. যে লোকটা ফাইলটা এই বিল্ডিং থেকে ওই বিল্ডিং নিয়ে যেত সেই লোকটা চাকরি আজকে নেই। So with all the technological advances, a section of our human resource will be able to grab and they will prosper. And one section they will be able to grab it, they can't prosper. Real life scenario is তোমরা অনেক ছোটবেলায় কতবার ব্যাংকে গেছে জানি। 10 থেকে 15 বছর বয়সে যখন আমি কলেজে ছিলাম তখন 100 টাকা কিন্তু ব্যাংকে যেতাম, আবার পাসবই নিয়ে 200 টাকা জমা দিতে ব্যাংকে যেতাম। আমি লাস্ট 5 বছরে একদিন ব্যাংকে যাই, হোল সিস্টেমে জানি। আমি ব্যাংকে গেলে আমার সাথে কথা বলার জন্য ব্যাংকে 5টা এমপ্লয়ি থাকে, আজকে যদি এমপ্লয়িগুলো নেই কারণ প্রয়োজন নেই। If you are students of this generation, hardly you will do that. You start Google Pay, GPay, whatever, etc. তোমার সাথে কথা বলার জন্য ব্যাংকে যে লোকটি যে ছেলেটি আমি বসে থাকতো সেই লোকটি নেই, তারপর তার ইন্ডাস্ট্রিয়াল রিকোয়ারমেন্ট নেই। So all the technological advances created a super specialist and specialist job category. Those who will be able to grab it, they will prosper. And those who won't be able to grab it, they will be thrown out of the market. That is how market is going. And yes, technology, other things. We are here today just because of technology. And be sure about it. Technology can do what you can think about it. Say for example, আপনি এখানে একটা random sampling করে 199 কে 223 দিয়ে গুণ করতে বলি, probably একজন করে দিতে পারবে, including me. প্রত্যেকের ফোনে আজকে থেকে ক্যালকুলেটর আছে। The machine can do better than you and me. তো আমরা যত বেশি টেকনোলজি ডিপেন্ডেন্ট হব তত বেশি সোশ্যাল ইনইকুয়ালিটিস বাড়বে এবং সেটাই লাস্ট 500 বছরের ইতিহাস। এটি কোনো বাইপাস নেই। এবার আমরা হেলথ কেয়ার ইন্ডাস্ট্রিতে আছি। ইয়েস, টেকনোলজি মেড হেলথ কেয়ার আপ টু দ্য মার্ক। আমার ইন্টারফেস ইজ বেটার নাও। একটা সময় আমি যখন মেডিকেল কলেজে ছিলাম, গলব্লাডার অপারেশন হতো 1 হাত অপারেশন, 1 হাত ইনসিশন। Our big professors, যাদেরকে অ্যাপয়েন্টমেন্ট চাইলে বলতো তুমি আগে ডক্টর মানে এখন দাঁড়িয়ে থাকো, কিন্তু আমার ধৈর্য কত, তারপরে তো সার্জারি। তাদের ডায়ালগ ছিল বিগ সার্জনস গিভ বিগ ইনসিশনস, দেন কেম ল্যাপারোস্কোপিক সার্জারি বা কিহোল সার্জারি, ছোট্ট একটা ফুটো করে সেন্ট কালি হয়ে গেল। যারা আমাদের, আমি যখন কলেজে ছিলাম তখন যারা বিগ ডন ছিল, নেক্সট 5 ইয়ারে তারা মার্কেট থেকে হাওয়া হয়ে গেছে, কারণ সে ল্যাপারোস্কোপিতে জানে তার পক্ষে ক্র্যাক করা সম্ভব। যারা নতুন জেনারেশন থেকে উঠে এলো উইথ ল্যাপারোস্কোপি, দে আর ডুইং। আপনি যদি ইওর পেরেন্টস, আঙ্কেল, আন্টি, আপনি যদি গলব্লাডার হয়, তুমি কি বুঝতে পারো কে পেটে অপারেশন করে বিগ সার্জারি বিগ ইনসিশন? So all the seniors whatever saying that it is not absolute right all the time. It is good, but they also have to be flexible. হেলথকেয়ার ইন্ডাস্ট্রিতে এসে আমরা যখন টেকনোলজি ইউজ দেখেছি, আমাদের টেকনোলজি সত্যি প্রচুর সুবিধা করেছে, পার্টিকুলারলি অ্যাট ইন্টারফেস লেভেল, ডকুমেন্টেশন লেভেল, রিসার্চ, ইনোভেশন। উই অল নিড ডেটা। উইদাউট ডেটা উই ক্যানট ডু এনিথিং। একটা স্পেসিফিক ডাক্তার চ্যানেল করতে গিয়ে একটা ড্রিপ জলকে 5 বার ফোটাতে হচ্ছে তাকে, এইটা জানবার জন্য উই নিড ডেটা। Each and every point we need data. That's how IT industry is now blooming. But don't worry, that industry will be within next few years will be taken care by AI. আজ থেকে 20 বছর আগে একটা IT ইঞ্জিনিয়ার পাস করলে বেরোলে যে মাইনে পেত, আজকে থেকে মার্কেট ভ্যালু তার 10 টাইমস হওয়া উচিত। We calculate around 8 to 9% inflation rate. বাট আনফরচুনেট ট্রুথ হচ্ছে তখন যে আমি তাদের কাছে কম পাই খোঁজ নিয়ে দেখতে পাবেন why that glamour already gone, it's not there. Now there are a lot of things that is managed by system generated AI driven mechanisms. আমাদের অত ম্যান পাওয়ার দরকার হচ্ছে না, that is also true. আজ থেকে একটা লোককে যদি প্রত্যেকের মাথায় মানে বুকে কান থেকে আসে তো দেখি যদি আমাকে হার্ট সাউন্ড শুনতে হতো on an average with expert ear and hand it should take 10 to 15 minutes. আজকে থেকে আমি কি করছি ইকোকার্ডিওগ্রাফি করিয়ে দিলাম আছে I am losing my clinical eye. Machine is doing that job with more perfection. এটাতে মনে হতে পারে যে আমি আগে 1 ঘন্টায় 6টা রোগী দেখি এখন 1 ঘন্টায় 12 জন রোগীকে দেখতে পারি দ্যাটস ট্রু সত্যি কথা কিন্তু এটাতে যেটা সমস্যা হলো এই টেকনোলজিক্যাল অ্যাডভান্সমেন্ট আমরা ডিপেন্ডেন্ট হয়ে যখন পড়লাম এই যে একটা পেশেন্টকে দেখলাম তার জন্য টাইম দিলাম সেই টাইমটা তার সাথে কথা বলতে আমার গল্প করতাম সো হিউম্যান ওভার ইন্টারফেসটা কমে গেল আমি একজনের সাথে 10 মিনিট ঠান্ডা মাথায় তার সাথে তাকে বোঝার চেষ্টা করি বা সে আমাকে বোঝার চেষ্টা করে তার কোয়ান্টাম এন্ড কোয়ালিটি অফ কমিউনিকেশন যেটা হওয়া উচিত ছিল সেটা কিন্তু এখন হলো ডিস্ট্রিবিউটেড হয়ে গেছে ওয়ান সিচুয়েশন another situation খুব কমন জিনিস হসপিটালে ঢুকলে কেউ একজন ব্লাড প্রেশার দেখছে হাইট দেখছে ইটস ভেরি কমন পিকচার পালস কত বিপি কত একজন সিস্টেম এসে দেখে গেল নাও ইউ ক্যান ইমাজিন ইন এ সেটআপ যেখানে সারাদিনে 1000 রোগী আছে 1000 রোগীকে ব্লাড প্রেশার দেখা পালস দেখা হাইট ওয়েট নেওয়ার জন্য কিছু না ভার্চুয়াল সিস্টেম চাকরি ছিল আজকে এসে দাঁড়িয়ে পড়ুন দেওয়ালে মেজারমেন্ট করা আছে যখন দাঁড়াচ্ছে এটা প্ল্যাটফর্মের মধ্যে ওয়েট বেশি আসা মাত্রই আমি ইলেকট্রনিক মনিটর লাগিয়ে দিলাম এভরিথিং ইজ রেকর্ডেড 10 জন সিস্টেমের কাজ একজন সিস্টেম করে দিল গভর্নমেন্টের এর ইমপ্যাক্ট কতটা জানি না প্রাইভেটের ইমপ্যাক্ট আছে তাহলে 10 জন সিস্টেমের চাকরি চলে গেল একজন রয়ে গেল সো টেকনোলজিক্যাল অ্যাডভান্সেস স্কোপ যদি আমরা বেসিক্যালি একটা থাকি যে সিস্টেমটা টেকনোলজি ইউজ করছে এটা বুঝতে হবে আলটিমেটলি সে টেকনোলজি কেন ইউজ করে তার বিজনেস প্রফিট হয় খালি করে আজকে যদি আমি 10 জন সিস্টেমকে মাইনে দিয়ে রাখি আমি যদি একটা হসপিটালে ওনার করি আমি দেখবো উপরে পাওয়া প্রচুর ঝামেলা একে গভর্নমেন্ট বলে দিয়েছে 2 বছর প্রেগনেন্সি দিতে হবে উইথ পে তাহলে আমি 10 জন লোকের বাড়িতে 10 জন ঝামেলা হবে আমি ঝামেলা ধরে নেব আমি মেশিন কিনবো 2 লাখ টাকা খরচা করবো একজন মহিলাকে রাখবো সেটাও রাখবো কিসে কন্ট্রাকচুয়াল ঝামেলা করলে বলতে গেলে বাবা আপনি যান তারপরে আরেকজন রাখবো তো টেকনোলজি অলসো হ্যাজ দিস ফর্ম লুপহোলস আমরা যখন কোনো কিছু ইউজ করি আমরা সেটা লুপহোলসটা ইউজ চোখে দেখি না কারণ আমাদের সবসময় মনে হয় এটা আমাদের ভালো হচ্ছে আজ থেকে 15 বছর আগে হয়তো সবার কাছে মোবাইল ফোন ছিল না মোবাইল ফোন এসে গিয়ে আমরা সবসময় মোবাইলে বসে রয়েছি আপনি বাড়িতে গেলে আমার মোবাইল টিভি দেখে আর সে পরে সারাদিন আমার মেয়ে ক্লাস 8 পড়ে তার নাকি সারাদিন মানে স্কুলে আর কলেজে ঘন্টা আপনার শিখে না তার সে আমাকে বলে গ্রুপে পড়াশোনা হচ্ছে কিছু বলার নেই আমি বলতে পারছি না মোবাইল থেকে বুঝতে পারছি সো রিয়েলি ইন্টারনেট আর টেকনোলজি মোবাইল টেকনোলজি আমাদের প্রোগ্রেস করি there is a time to rethink about it but yes for a partition level interface level documentation level and efficiency level technology is far better than human being 10 জন সিস্টার মিলে যদি 1000 লোকের ব্লাড প্রেসার আর হাইট ওয়েট মেপে থাকে তার ওভারঅল দিনের শেষে অ্যাকুরেসি রেট is around 70% কিন্তু আমি যদি মেশিন দিয়ে মেপে থাকি ওভারঅল অ্যাকুরেসি রেট is 100% you can't deny that that's it how technology is basically dividing us in the name of that technology helping us.
Yes, Durga, you want to add something on this?
Thank you, Dr. Dash. Dr. Dash has mentioned many things. I will just add certain points of the technology, which has been implemented in the government healthcare setups. Just a brief overview. That is e-office. Previously, as Dr. Das rightly said, that file movement was through one routine or attendant who used to take one file to another person or from that building to that building. But now, government has improvised e-office. Through e-office, we enter the file, like a file number is being generated. We scan the letter or maybe any estimates given by PWD departments or whatever. We upload that, and in the list, it comes like where to we are uploading and to whom we are uploading. So maybe the CMO, or maybe the DHS, or maybe the Director of Medical Education, we are uploading. So now, like today, present scenario is we have e-office in hand. Also, we have the Know Your Doctors. Know Your Doctors folder. Like just go to the Google page and open the health website, www.health.gov.in. Just open it. You will find all the portals that are showing in the right-hand side corner and the left-hand side corner. Even our service, even the employee service, this is from the other scenarios I'm talking about, other administrative parts I'm talking about, establishment parts I'm talking about. So all those things are being put into the computer. And likewise from one point, if you have like if you are working for maybe outside, if you want to add something from that place also, you can add or maybe edit the documents in the doctor's name also. So we have the telemedicine part, that is Shastro Ingi VC. Previously, as you all know, the government, as Dr. Das rightly said, government caters to mostly BPL patients and to the poor patients they have. They cannot afford much. That is why the government hospitals are there. Even we have seen some posh citizens also taking privilege from us. Many of the posh citizens, they come to us, they don't want to stand in line or in queue. I was this, I was that. Okay, fine. We give all sorts of privileges.
The ministers also.
Even we also take that privilege. It's no harm saying that. I'm working in my institution, so I am taking a bit of privilege. I want to go to the doctor and without giving any line, I want to get checked by him. So this is the privilege that we are taking. And it's very true. But the poor people, those who are staying in remote areas, remote villages, they cannot come to the hospital. The mobility challenged patients, the physically challenged patients, can they come from any remote areas to any government institutions for treatment? So much of difficulty they have to take, so much of pain they have to take, so much of finance to be involved for bringing those patients over there. Even the 102 ambulance also might say, over there it is going to take long time, 2.5 hours, 9 people to travel, so all these things might happen. For this, telemedicine has come into force, where the patients from any point, from any health wellness center, from any UPHC, from any PHC, they can approach the CHO and they can get consultation of any doctor at that point of time. This is reducing the patient, financial part also is being taken care of. The patients, if they are not getting prone to hospital infections, the moment we get inside the hospital, first and foremost, what we think, okay, we are entering the infection zone. So many patients are suffering from so many diseases. And what we do after we reach home from the hospital, straight away, we fresh ourselves, we refresh ourselves, we wash our clothes, isn't it? We do. If we go to any hospital, after coming back home, we do this. But through telemedicine, we are reducing the risk of infections to any sort of patients. So this thing is Ayushman Bharat. That is another portal. Ayushman Bharat, I believe all the medical practitioners and the nursing staffs and the administrators have enrolled into the Ayushman Bharat program. The patient part is yet to be implemented. If the patients get registered into the Ayushman Bharat portal, that is when ID is being generated, the moment they come into the hospital, the thing is that they would get all medicines, all facilities absolutely free of cost. They don't have to bear a single price if they enter into the Ayushman Bharat portal. But from the patient point of view, it is still yet to be implemented. There are blood bank portals, radio frequency identification number. Now in the government setup, blood bank portals has been implemented where the number of bags, the donors, what amount a patient has to give if anybody comes from the outside. All those things are being taken care by the blood portal. That is the radio frequency identification number is being generated. That is maternal death portal. That is child death surveillance portal. So many portals are being arranged that at glance the patients and the doctors can view their status. And those things can be documented and taken care of immediately. Thank you so much. Technology is advancing and going to advance more in the government setups. We believe that it can reduce the medication errors. It can reduce all the physical errors that is very much prone in any health setup. All these are aspects of quality. So please do go through all this. And thank you so much.
Okay, though both of you are from two various fields where for the whole day you spend your days with the patients as well as the other problems, but I think our students who are both from the UG and PG level, today whatever you have addressed, I think all of them have understood. Yes, you have enjoyed. Okay, do you have any questions? Any one of you? If you have any question, please raise your hand. Shubhankar will take the mic to you.
So good evening, ma'am. So my question is, in recent times, e-medical records are very common in both public and private sector. But as we know that in e-medical records, there is a high chance, and there are many cases that the records get destroyed due to technical glitches or cyber crimes. So what are the measures we should take to reduce this risk? Because patient safety, first priority is patient records also.
Thank you for the question. What I believe, like e-prescription is yet to start in the government sector. I believe it has started in some of the medical colleges, but cybercrime, we haven't yet heard of any such crimes as yet. As far as e-prescription is, comes into force in any hospital level, that is being viewed centrally, that is being viewed by the state, that is being viewed by the district. So if any cybercrime happens, if it happens in that institute, there's nothing to worry about. We have the other setups fully operational 24/7 from where the data could be retrieved. Thank you.
Just to add one line. লোকে চুরি করে কেন? টাকা পেতে হবে। রুগীর টাকা চুরি করলে কেউ টাকা পায়। Don't do it.
I have a question to Dhruva particularly. You are saying a lot of things about the government hospital and the facility, but sometimes we hear that the newborn baby is tracked by a dog, and there are cats and other animals roaming free in the world. and there is hardly any hygiene in those kind of hospitals. Is it all about calorie show in the web portal, or is really?
So this is not the gallery show. Well, the thing is that previously it might have happened at that point of time. I wasn't there in the service. Up to have heard what you were saying. Now, but the thing is that the intensive cares on the the maternal wards, all those wards are not situated in the ground floor of any hospital building in the present scenario. Okay, those are situated in the top level, like maybe the sixth floor or in the fourth floor or in the fifth floor, where the maternal segment is there. It has directly a unidirectional flow with the labor room and the maternity. And likewise, as you were saying, infiltration of stray animals, stray cats, stray dogs, those things I think are not prevalent nowadays. Like the management is taking good care of it. There is certain agency that if any cats or any dogs, infiltrate into the into the institution, those organizations, if we called, they pick up all those cats and dogs and they keep it, put them in a separate zone or maybe in separate areas. Now the thing is that this is one of the quality aspects also, sir. Like we say that the hospital should be totally free of any stray animals or cats or dogs to make it safe environment. We should provide safe environment to all the patients. We are trying, and many of the hospitals have achieved also. Like if you visit my hospital, when you come to my hospital, I can show you we have achieved. Like medical colleges present scenario, I don't know, but when I was working in Arjikar, at that point of time, yeah, stray animals used to, they used to flock in.
Program free.
Yes, but then those agencies came in. The veteran agencies came in. We used to give them call and they used to pick up. But one thing is very important, sir. Though we say that we must keep everything clean, but it is actually our practice. It actually depends on us. আমরা যদি খেয়ে খাবারটা উঠেনে ফেলে দিই, আমরা একটা বিড়াল আর কুকুরকে দূর থেকে ইনভাইট করছি, বাবা আসো এসে নোংরাটা করো। The thing is that it depends on the users. আমি ভাবতে নিউজে কাজ করেছি, আমি বিএম বিল্লায় গেছি, আমি তারপরে গুডল্যান্ডসে গেছি। ওখানে এইসব হয় না। কেন হয় না? বিকজ ওখানে পেশেন্টটা তো খুব একদম মানে রেস্ট্রিক্টেড, লিমিটেড। মানে ওখানে তো ওই জিনিসগুলো নেই। আপনি তো পুরো একটা ওপেন, ইটস আ বিগ এরিয়া। এখানে একটা বিল্ডিং, ওখানে একটা বিল্ডিং, কিচেন বিল্ডিং বাইরে। সো ওখানে কি হচ্ছে, পেশেন্টরা খাবার পাচ্ছে, এবার খাবারগুলো যারা নিচের ফ্লোরে আছে, অনেক সময় ফুড হ্যান্ডলার্স যারা, তাদেরও তরফ থেকে যে ভুল হয় না, ইট হ্যাপেন্স। তারা হয়তো খাবার একটা কুকুর এলো, খাবার এসে আদরের চোটে রাখতে গিয়ে খাবারটা দিল নিয়ে একবার দিলি, নাও ইউ কাম, ইউ হ্যাভ ইনভাইটেড দেম। The thing is that it depends on the users also, sir. But everywhere, I believe, all the departments, all the hospitals are trying nowadays. If you visit one or two, I think you might get a picture of this. We are trying to give them.
Thank you, madam. Just a small supplementary question. We see two patients are sleeping in a single bed, and in the corridor also, in the floor also. What about this?
Sir, this thing I don't think that we could, totally debar it from the government setup. Like, but in our institute, I'm talking on behalf of our institute as because we have got Kayapal. We are affiliated with Kayapal, with Lakshya, we have faced Plus also at the central. Like, we don't, indulge double bedroom of the patients. What we do, patients will come, we cannot say no to them. At least we can say, we can put a stamp on the BHC, on the bed ticket, regret no bed vacant, and we can refer it to the other hospitals. But in any emergency, suppose if any maternal patient comes, what we do, we arrange beds. There are certain trolley beds also, kept in different wards. From there, we shift the patients to all those beds, where hand beds are there, the oxygen is kept down, so that the doctors can give treatment. Thank you so much, sir.
have a question. It's your journey and about technological advancements happening in Iran. So, how quickly you see that are going to do surgery on patients and few doctors won't be required in because it is required now. And the basic level of surgery, not very complicated surgery, but very basic level of surgery, whether it's possible for robots or robotics to come and replace a human doctor.
Yes, sir. Absolutely. Calculator can calculate more faster accuracy than you can. The robot can do surgery better and more efficient than I can. Till now, robotics is a high cost phenomenon. It's not in the mass. If it is available at a rate of, say, for example, laparoscopy cholecystectomy in any other hospital, if robotics is that cheap today's world, then 50% laparoscopic surgery will be managed. They won't require the system. Everything in a system, if we consider as a nation and we or belong to a system, the system has its own checks and balances. Say, for example, if you go to any of the hospitals nowadays, you won't find that somebody is measuring your blood pressure with that kind of pump. That's gone. And I think you are quite senior person. You have seen somebody in Uttam Kumar's film, the anesthetist is pumping a bag, bag. Now it's gone. So technology has made our life easy, but at the same time, as I told you before, that it is also curtailing the certain things we won't be able to grab. In a foreseeable down the line 50 years of future, there is no probability that robotics will come across in India so that can have a significant chunk of difference. But yes, AI is there, AI is gradually taking up, and definitely in due course of time, in a horizon of 10 years, we don't need so much of medical doctors. That days are coming. So nowadays, who are actually getting into the medical world as a student, they will face the problem because they will have to study 5 years for graduation, 1 year for internship, another 2 years for post graduation. So it's 5, 3, 8, and establishing the average practice another 2 years. So who is entering in the medical college today, they will have the maximum casualties. I say this casualties because once somebody in the medical world, there is no side effect. It is very difficult. And being a doctor, I am ashamed to say that doctors are more poorly groomed person other than themselves. That is another problem. Somebody who is a doctor, they don't understand finance. They have almost zero communication skill. Almost zero communication skill because it's never proven. They only can think about the disease, there's a management, and they think, okay, fine, I'm super boss. It's not like that. সকালে ঘুম থেকে উঠলে আপনাকেও ব্রাশ করতে হবে আমাকেও ব্রাশ করতে হবে আপনাকেও বাইরে যেতে হবে না হলে ম্যাডাম বলবে ভাই এবার তুমি বেরো আমারও 10 টাইম সো দিস ইজ দ্য বেসিক লাইফ স্কিল প্রবলেম হচ্ছে যারা একাডেমিক ইন্ডাস্ট্রিতে বড় হয়েছে তারা একটা সার্টেন স্টেজের পরে মনে করে এগুলো আমার কাজ না ইটস নট লাইক দ্যাট এটা হতে পারে না. So that's how they get separated from many things. AI is doing a remarkable work at this moment in India through Sankar Netralaya এবং Microsoft একটা project আছে যা অটোস্কোপ দিয়ে দেখা হয় এবং same one technician, one scope in a car roam around the village of Tamil Nadu. It is patronized by Sundari Pichai because he is from South. So already completely funded by Sundari Pichai group. So they are doing fantastic job. ডাক্তাররা কি চোখে দেখে যে রেটিনা থেকে ক্যাটারাক্ট ডায়াগনোস করছিল, that is the pilot model. The machine diagnosed cataract is 100% accuracy rate, which even a doctor can proudly say that I can diagnose cataract at 100% efficiency rate. So it's coming. So that means even the 5% of somebody who is having cataract, they used to come to a doctor. Now they don't need to come to a doctor for visit. Till now they have to come for the operation. But days are coming when robots can do, then that is also one. So that days are coming. But fortunately, I will be directed.
Any more questions?
So my question is to both of you. No, the technology has really helped the healthcare sector a lot, but the cost for the implementation and maintenance of the technology and even for the training is a significant barrier for the adoption. So especially for the smaller providers, especially for the smaller healthcare providers and who have good sports settings. So my question is that how to overcome this barrier?
Uh, will you love to be first girl of your batch? Will you love to be first girl of your batch? That's your answer. It's a competitive world. Whoever will be able to accommodate it, able to finance it, they will be at an elevated level. Who won't be able to do that, say as well. Say for example, the same girl like you, somebody whose father could not afford the fees of education. Probably she may or may not be better capable than you are, but she should not have the opportunity to come and talk to me and madam. So that's the model. Survival of the fittest, Madam told. It is Darwinian principle, and in today's world, this fittest comes with an economic fitness, not the physical fitness. There, you are a guard. That's what I'm saying. There is a one WhatsApp message roaming around. This is for last for few years. Don't go for 6 pack apps. Go buy six cards. That's life.
Raj, whatever you were saying is just reverse to what people are thinking nowadays. Anyone else? Because we have a question from Durgapur, also from our Durgapur campus. Through this Facebook live streaming, we are also watching you. Our BHM and MHS students from Durgapur campus. So they also have a question. Just a minute. Let me have the question. It is for both of you. How to manage ethical considerations? How to manage ethical considerations of data management when third parties are involved? It is a question from the Durgapur campus students.
Thank you. Ethical management and the data management. Ethical management is guided by the various law and fair laws, and data management is guided by the IT Act, Information Technology Act 2015. So if third party is involved, the primary responsibility of the institution is not the third party. Say for example, I am running a hospital A, and I'm not an IT guy, so I have outsourced this data management to any organization called IT or ITB. So if any breach happens and if there's any legal issues, I will be liable. I can have agreement that this company has to comply with whatever compensation I have to give. But fundamentally, it is the responsibility of the healthcare institution, not the IT company.
I think it is the last question from. Okay, we have two more. Please. So the session was interesting indeed because this is the first time I am watching the students so enthusiastic for the questions.
So can you explain me how does the technological advancement increase the patient rights? Can you just brief us?
If you know what is your right, that's the best right. Awareness. লোকে কথা বেশি বলছে, গুগল আছে, ওয়েবসাইট আছে, এখন everybody knows it's by right.
But how the technological advancement help?
IT technology, this is technology. গুগল কিসে দেখছে? আমি তো কারো বাড়িতে গিয়ে শিখিয়ে দিয়ে আসছি না আপনার এই রাইট আছে, সে যখন জানছে কি করে জানছে? Technology, this is the fundamental. And next, it is now WhatsApp University, Facebook University, and YouTube University is basically teaching everything. That's everybody knows there is something called patient rights. Probably you are not from law background. Do you know there is a women's right? Yes. How? As you know there is something called women's right. Similarly, if you are a patient, you will also know there is something called patient right. It's just because of technology. And Right to Information Act is also there, Madam just mentioned this, but be careful, Right to Information Act usually doesn't encompass healthcare data. It is outside healthcare institution except for few situations. Say for example, one criminal is admitted in a hospital and police authority wants the information, it is outside Right to Information Act. But if I am as a person asking the same question, it comes under the Right to Information, which is basically holding me to ask that question and holding the institution to provide that answer.
So, I have a question for both of you. If, since it is on technological advancement and patients, we are seeing that the government hospitals has come a long way, for improving in all these aspects. But still, the people who have got Mediclaim, they don't go to hospitals. They go to only private hospitals. In spite of the fact that we know that we have got very good machines and very diagnostic good machines in the government hospitals. We know that the infrastructure is very big compared to the private hospitals. But still, people who have money, they go to private hospitals. So, is there any problems about the reliability of the perception about the government hospitals is concerned? But it is really true that people don't get that care when they go to hospitals, especially the government hospitals.
Sir, it's not a question of government or private hospital. Even our ministers goes to PG hospital, Woodburn. Sorry.
Yeah, but we don't get opportunity in Woodburn. The general people can go to
Sir, pyramid was there, pyramid is there, pyramid will be there. If you are not at the top of the pyramid, you can't expect the facilities of somebody who is staying at the top of the pyramid. And now I am coming to your question. Mediclaim is a business entity. All the Mediclaim company is running their own business. What they are actually capitalizing, they are selling sense of security. It is very easier to sign a Mediclaim form and have a Mediclaim contract, but it is very difficult to earn that money from Mediclaim company. This is number one. And number two, government hospital per se, it's free. Mediclaim, whatever is the company and whatever is the format, as per IRB norms, it counts as the compensation of healthcare expenditure. As officially government healthcare is free of cost, so there is no question of compensation of healthcare expenditure.
That is my question. That even if it is free, why people don't go to government hospitals?
That's your choice.
No.
Sir, if I give you the choice to have a Mercedes and Maruti Alto, probably you will have Mercedes.
Another thing I have observed, because I live very close by to Congo Hospital, there is a problem so far the dalals is concerned. If you want to get admissions, there is a problem of mediators. I don't think that hospital cannot do anything so far the mediators is concerned.
Sir, you are saying some kind of agency and middleman.
Middleman, not agency, middleman.
Middleman. It is, yeah, I get your point. Whenever there will be crisis of resources or availability of resources, then as a consumer, you will always try to grab it by many means. So, Sir, you have to realize certain things. Smarter guys will rule. In that bracket, somebody smarter, he will find a double first. Middlemen are always smarter. In this middleman concept, India is not recognizing it. It's not a recognized profession, but if you go out of India, it's a recognized profession. And until proven otherwise, everywhere there is this middleman concept. Otherwise, nothing will exist. Sir, if you want to listen the harsh reality, then I will say the one line. Managerial skill is skill over certain skill, not a skill in the air. What you are teaching is skill in the air. In healthcare industry, if you send any of them, can you name one job which is required for healthcare can be do? One thing, one role. Exactly. So it is you are doing something skill in the thin air, not over and above certain basic skill.
That is why confidence comes into place. That is why, sir, so many nuances have come out in the previous years and in the previous to the superintendent chamber, to the deputy superintendent chamber, to the administrators. And the demand centralization mechanism is working. There are different signages where we portray বিনা সরকারি রসিদে কাউকে টাকা দেবেন না। এইবার যদি কেউ দিয়ে দেন, that is up to his or her discretion. এইটা স্যার আমরা এখান থেকে বসে অ্যাভয়েড করতে পারবো না। এটা হচ্ছে নিজেদের চেষ্টা। যেরকম আমরা গভর্নমেন্ট সেটআপের চেষ্টা করছি কিংবা প্রাইভেট সেটআপের সবাই চেষ্টা করছে, যারা ইউজারের তাদের তো সেই জিনিসটা বুঝতে হবে। তারা যদি বলে না ওর তো মিষ্টি খাওয়ার জন্য 20 টাকা দিলাম, exactly sir, exactly. Actually, what we are doing under quality, first is literacy is not there. It's a very vital point, sir. Government setup, those who are coming, they are not so much literate. Few are, very few. Okay. Now, that is for health education, awareness companies. Like we arrange for Pathonatica. Many sorts of things are being organized by the health workers, by the nursing students. That's what one should do. After giving, now it absolutely depends on the users also. They must and they should understand this high. Thank you, sir.
Thank you to both of you.
Shurita, I think that after this session is over, definitely we can have a real life survey project with the students that why people are not interested for the government hospitals, though they have so much good infrastructure, facilities and all. And what about the medical facilities they are having and people are not aware of, right? It will be a good project for our students.
Sir, there is a concept. If you can impress only, then you will be able to convince. You may or may not know that is one of the line. Yes. Now, for impress, the investment amount of a corporate house, that is, you cannot imagine. Say, for example, you may using Samsung phone. One good Samsung phone is around 50,000. And if you go to Apple, it will be more than 1 lakh. Do you know it is the turnover of phone business? Apple has highest revenue than any other company. So now question is why? The feature Apple predict or Apple announce, most of them probably don't need it and can't even use them or not anything. It gives a sense of pride. So when our societal psychology is something which is not my need, but I can have it gives a psychological proud feeling. That is the fundamental reason somebody is coming to corporate hospital. If you have a gallstone operation and if you come to government hospital, আশেপাশের লোক বলে এত যুক্তি কিনে বাবা ফ্রিতে অপারেশন গভর্নমেন্ট ক্ষেত্রে if you come to Apollo treatment is. If you have little more money, you can go to Singapore. Power. Singapore can treatment body. It is same thing, same shirt, metro থেকে 500 টাকা কেনা যায় আর ভ্যালুয়েশন ওটার দাম 4000 টাকা। 4000 এর যে জামাটা কেনা সে ভালো হয়েছে। আপনি যদি অ্যাপোলো দিয়ে করে আসেন, আপনি আলোচনা করতে করতে অ্যাপোলো গেছিলাম কি ব্যবস্থা। কিন্তু সরকারি হাসপাতালে যদি যান তখন আপনি বলেন না কারণ আপনি খরচা করেন। কারণ সেটা আপনাকে প্রাউড ফিল করাচ্ছে। So societal level proud feeling হয় পিরামিডের উপরে সেই প্রাউড ফিলিংটার জন্য কর্পোরেট ইন্ডাস্ট্রি হিউজ অ্যামাউন্টে খরচা করে যেটা গভর্নমেন্টের করার কথা না গভর্নমেন্ট করে গভর্নমেন্টের এখানে যদি আজকে কলকাতা শহরে জানেন সবথেকে বেশি লিভার ট্রান্সপ্লান্ট কোথায় হয়েছে পিজি হসপিটাল এই নাম শুনেছেন প্রথমবার যখন হয়েছিল গভর্নমেন্ট লেভেলে কেউ একটা রিপোর্টিং করেছে কিন্তু কলকাতা শহরের সিটিতে যদি নাম লেখেন আপনি লাস্ট 5 বছরে দেখবেন অ্যাপেলো 5 থেকে 7 বার অ্যাডভেটোরিয়াল দিয়েছে আমার এখানে লিভার ট্রান্সপ্লান্ট আলটিমেটলি তো পৃথিবীটা পয়সা দিয়ে চলবে
আমি একটু একটা জিনিস কোয়ালিটি নিয়ে বলবো জাস্ট ইন আ লাইন কোয়ালিটির একটা কনসেপ্ট হচ্ছে if you can measure it you can understand it. If you can understand it, you can control it. And if you can control it, you can improve it. So, government hospitals, please do come to government hospitals. We are there to help you out. Don't, no hesitation, there shouldn't be any hesitation from your end. We are there to give equivalent service as much as we could render. And please, awareness campaign also from the students are also required, as because you people are studying in this field or in this genre only. So please try and make the health service, reach a benchmark. Thank you so much.
Since we are running out of time, we're already late. I don't think we are going to take any more questions today. So here we are at the end of the session. Now off to the actors again.
Now I would request Professor Navanita Datta to present the memento to Dr. Jayanta Dash as an expression of our gratitude. Now I would request Professor Prashant Kar to present the memento to Mrs. Durga Banerjee as an expression of our gratitude. Thank you, speakers, for your words of encouragement. It is the privilege of NSHM Business School Hospital Management Department to host this panel discussion and enlighten the audience. Thank you, audience, for your patience. Thank you to our principal, sir, and faculty members of the Department of Hospital Management for arranging such an enlightening and relevant session. Thank you.